Welcome to the deep dive. Today we're tackling a really significant area of cardiovascular medicine, the treatment of thoracic aortic aneurysms, or TAAs.
That's right.
And we're going to specifically explore thoracic endovascular aortic repair, T-VAR, as it's more commonly known.
Yep, T-VAR.
Think of this as your shortcut to understanding the evolution and current best practices in this field, drawing from some really in-depth surgical literature to extract the knowledge you actually need.
And it's important stuff. These thoracic aortic aneurysms are a major health concern, a leading cause of death in the U.S., actually.
Really? How many?
Sadly responsible for over 11,000 fatalities every year. And what's quite striking is we're seeing more diagnoses.
Why is that?
Well, it's likely a mix of things, an aging population definitely, but also more frequent better chest imaging for other reasons, plus just increased awareness.
Makes sense. And who typically gets diagnosed?
The average age is around 65, and it tends to affect men a bit more often than women, about 1.7 to 1.
Okay, let's just quickly clarify. An aneurysm, simply put, is an abnormal bulge or widening in the aorta, our body's main artery.
Exactly, that big pipe coming out of the heart.
And today, we're zeroing in on aneurysms in the descending thoracic aorta, DTAAs. Serious condition. The key question is how best to manage it. And that's where T-VAR comes in.
Precisely. Our mission here is really to distill the most critical insights about T-VAR for you.
So what are we covering?
We'll look at when it's recommended, the indications.
Yeah.
The specific devices used, there are a few key ones now. The very detailed planning that goes into it.
Crucial, I imagine.
Absolutely. And of course, the potential complications and what the long-term outcomes look like for patients.
And where's this info coming from?
We're drawing heavily from the latest clinical practice guidelines for T-VAR, from the Society for Vascular Surgery, the SVS, and also the comprehensive experience documented in Rutherford's Vascular Surgery and Endovascular Therapy. Good sources.
Okay. And it's important to know this isn't some, brand new experimental thing.
Not at all.
Here's where it gets really interesting. The FDA approved the very first T-VAR device, back in 2005?
That's right, 2005. It feels like a long time ago now in med tech terms.
And since then, it's been a real game changer. It quickly became the preferred, often the standard of care for DTAAs and other thoracic aortic issues.
A true paradigm shift in treatment. So let's get into those specifics. When is T-VAR actually the recommended way to go?
Right, the indications.
The criteria are pretty well defined now. If an aneurysm is causing symptoms, or if it's ruptured, well, then you intervene regardless of size. That's urgent.
Makes sense.
For the asymptomatic ones, the ones you find incidentally, the general guideline, and this is a strong SVS recommendation, is a diameter of 5.5 centimeters or greater.
Okay, 5.5 centimeters, that's the magic number.
It's the main threshold, yeah.
Well,
Or if it's expanding rapidly, that means growing 5 millimeters or more per year.
got it. So size or rapid growth, what's the risk level associated with those sizes? Why 5.5?
Well, the risk of rupture, it really escalates as the aneurysm gets bigger. Less than 4 centimeters, the risk is pretty low, negligible really.
Okay.
But once they hit that 40 to 59 millimeter range, that's 4 to 5.9 centimeters, the 5-year risk jumps significantly, maybe 16% to 31%.
Wow, okay. That's substantial.
It is. And when you get over 60 millimeters, so 6 centimeters, the annual risk of rupture is around 15.6%, a really significant danger each year.
So intervening before it gets that big is key.
Exactly. The SVS guidelines also note that for patients who are considered high risk for traditional open surgery, you might actually wait a bit longer, maybe intervene at diameters over 6 centimeters. It's always that balance.
Risk of the aneurysm versus risk of the procedure.
Precisely. A risk-benefit calculation for each individual.
But are there times you'd go in earlier, even if it's smaller than 5.5 centimeters?
Absolutely. Specific situations warrant it. Like if the aneurysm shape isn't the typical round bulge, if it's what we call non-saccular,
Okay.
or if it's causing symptoms, even if it's smaller. And a big one is aneurysms linked to certain connective tissue disorders.
Like Marfan syndrome. We hear about that with aortic issues.
Marfan's are the classic example, yes. But also Loeys-Dietz syndrome, Ehlers-Danlos, Turner syndrome, even having a bicuspid aortic valve. These conditions weaken the aortic wall.
Making it prone to rupture or dissection at smaller sizes.
Exactly. The tissue is just inherently weaker. And it goes beyond those named syndromes, too. Specific gene mutations are known culprits.
Like which ones?
Things like SMAD3, TGFB2, TGFB3, MYH11, ACTA2, MYCK. These are linked to both dissections and aneurysms.
Right.
So in patients with these known genetic predispositions, repair is often considered earlier, maybe when the aneurysm reaches 45 to 50 millimeters.
So 4.5 to 5 centimeters instead of 5.5.
Correct. The guidelines are quite specific for some.
Mm-hmm.
Elective repair around 50 millimeters for Marfan, and maybe even 40 to 50 millimeters for Loeys dates, which can be particularly aggressive.
So the key takeaway is genetics matter a lot here, lowering that threshold.
Definitely. It's not just about size in those cases. The inherent risk is higher.
What about the location within the thoracic aorta? Does that play a role?
It does seem to. Aneurysms located in the mid-descending thoracic aorta tend to grow a bit faster, on average.
Faster. How much faster?
Well, your typical degenerative aneurysm might grow, say, 1 to 2 millimeters per year. But these isolated DTAAs, especially mid-descending, can average more like 3 millimeters per year.
That's a noticeable difference. Certainly factors into surveillance and timing.
Absolutely.
Now, what if someone has an aneurysm, but it doesn't meet these criteria for repair yet? What's the plan then?
Good question. The focus shifts entirely to risk factor management and medical therapy. This is a high-quality SVS recommendation. Meaning aggressive blood pressure control,
Yeah.
managing cholesterol, absolutely crucial smoking cessation if they smoke. Basically, optimize all cardiovascular risk factors.
To slow down growth and reduce other heart risks.
Exactly. It's about managing the whole patient.
Okay, so we've covered the when for T-VAR, but is it always the best choice? Is there debate compared to open surgery?
That's a really important point. Back in 2016, a Cochrane review highlighted that there was still some clinical equipoise, basically uncertainty about whether T-VAR or open surgery was definitively better long-term for TAAs.
Why the uncertainty?
Mostly due to a lack of really robust long-term comparative data at that time. However, the game has shifted somewhat. The more recent 2020 SVS guidelines, they strongly favor T-VAR for elective repair if the patient is anatomically suitable.
Suitable meaning their aorta fits the device criteria.
Yes, based on the specific instructions for use, or IFU, for the device being considered. That's a grade 1 recommendation now, backed by high-quality evidence.
But you mentioned long-term data was lacking before. Is that still a caveat?
It is, to some extent.
Yeah.
While T-VAR clearly shows benefits early on, reducing risks around the procedure itself, we still need more comprehensive data going out past, say, 5 or 10 years.
And there's another catch, isn't there? Surveillance.
Absolutely critical. Patients undergoing T-VAR need lifelong imaging surveillance. We had to keep an eye on that endograft.
So for younger patients, maybe open surgery is still considered more often.
It often is, yes. Because traditional open repair historically has lower rates of needing repeat interventions way down the line. So for someone with decades ahead of them, that's a serious consideration.
So it's a trade-off. Lower upfront risk with T-VAR versus potentially better long-term durability maybe with open surgery, especially for younger folks.
That's a good way to put it. Now, for patients who are already at higher risk for any major surgery due to other health problems,
T-VAR becomes more attractive.
Generally, yes. The risk-benefit analysis often tips towards T-VAR. And honestly, as we get more long-term data, there's growing support for T-VAR even in lower-risk patients, mainly because of that clear win in reducing those early perioperative risks.
Okay. Now, are there physical limitations in a patient's body that might make T-VAR difficult or impossible? Anatomical issues?
Definitely. The anatomy, specifically the aortoiliac system, that's the aorta and the iliac arteries going down to the legs, needs to be suitable.
That's the access route, right?
Exactly. We need a pathway that's wide enough and not too twisted or diseased to get the delivery system up there. If the anatomy is unfavorable, T-VAR gets much harder.
What else?
Also, if fixing the aneurysm means we have to intentionally block off important branch arteries supplying organs, well, the risks of doing that have to be weighed very carefully.
So what do you do then?
There are alternative techniques, things like snorkel or chimney grafts, fenestrated or branched endografts, which have built-in holes or branches for those vessels, or even hybrid approaches combining surgery and endovascular methods.
Trying to preserve blood flow.
That's the goal. Maintain perfusion to critical areas.
So it's not always straightforward. Sometimes you need these workarounds. Are there times when T-VAR is just completely off the table? Contraindications?
Yes, there are clear contraindications. If the patient's anatomy just doesn't fit the device's specifications, the IFU again.
Like what specifically?
Things like the neck of the aorta, the healthy bit above and below the aneurysm where the graft needs to seal, being too short or too diseased, or if the aorta is super angled, or if there's a ton of thrombus, clot, lining the aorta where you need to seal.
Okay. What else?
A life-threatening allergy to the device materials, nickel, titanium, stainless steel, graft material itself.
Right.
And very importantly, if the patient just can't or won't comply with that lifelong imaging follow-up we mentioned, elective T-VAR isn't appropriate then.
Because you need to monitor for potential problems. Yeah.
Exactly. Now, in very rare critical situations like active bleeding from an aortoesophageal fistula, a connection between the aorta and the esophagus, or an infected myconic aneurysm, T-VAR might be used as a temporary life-saving bridge.
A damage control measure.
Sort of, to try and stop immediate catastrophe. But even then, the SVS guidelines rate that as a weaker recommendation. It's not ideal long-term treatment in those scenarios.
Okay, so lock us into that decision. Let's switch gears now to the actual tools. What devices are we talking about for T-VAR?
Well, the technology here has really evolved. The endografts themselves have gotten much better over the years.
How so?
We've seen a clear trend towards lower delivery profiles, meaning they fit through smaller access vessels, big improvement, and better fixation, how they anchor in the aorta, better conformability, so they hug the curves better, and more precise deployment systems for the surgeon.
So accuracy has improved.
Definitely. Now, several devices have received FDA approval over the years, but some older ones aren't the main players anymore as newer tech came along.
Which ones are less common now?
Things like the Cook Zenith TX2, the original Medtronic Valiant with Captivia, the first Gore conformable tag. They've largely been superseded in the U.S. market.
So which are the current workhorses, the main devices used today?
Right now, there are 4 main players widely available and FDA approved. The Gore tag conformable thoracic stent graft with active control.
Okay.
The Medtronic Valiant Nivian thoracic stent graft system.
Got
The Cook Zenith Alpha device. And the Terumo Aortic Relay device Plus. Each has its own design quirks and delivery system.
Let's unpack those a bit. Starting with the Gore tag conformable with active control. That was the first one approved, wasn't it? The original tag.
That's right. Original tag in 2005. The conformable version came in 2012. And this latest one, the active control system, in 2019.
What are its key features?
It uses an EPTFE graft material, reinforced. Sutureless attachment, nitinol stent skeleton. The big thing with active control is this 2-step deployment.
How does that work?
It uses a nested handle, giving the surgeon more control. You can even tweak the angle of the leading end during deployment. It deploys partially first, allowing blood flow expanding from front to back.
Okay.
Then the second step fully expands it, but this time from back to front. And even after full expansion, you can still fine-tune the angle before the final release.
So enhanced precision.
Exactly. Oversizing is typically 6% to 33%. And interestingly, data from Europe showed that with this lower profile version, percutaneous access just through the skin, no big incision was possible in almost half the patients. That's a big deal for recovery.
Definitely less invasive. Okay, next up. The Medtronic Valiant Nivian.
Approved in 2018. This is Medtronic's next-gen platform. Lower profile than the original Valiant, about 4 French smaller, which helps with navigating vessels.
Easier delivery.
Right. It's a woven polyester graft, external nitinol stents, comes in 2 proximal end types, covered seal, fabric right to the edge, and free flow, which has bare metal stents at the top.
Why the bare stents?
The idea is they distribute the outward force more evenly in the aortic neck, potentially improving the seal. The Nivian is also longer than the original, offers smaller diameters, has a shorter tip with a capture feature for positioning, and a hydrophilic sheath coating.
To help it slide through easier?
Yep, especially in twisty anatomy. Oversizing is recommended at 10% to 20%. The pivotal trial showed good results, no deployment failures, low reintervention rates initially, percutaneous access in over half the patients.
Sounds good, but wasn't there an issue with this one?
Yes, important point.
Yeah.
Medtronic did issue a voluntary recall in February 2021. Concerns arose from that same trial about stent fractures and subsequent endoleaks, so physicians were advised to stop using it for new patients.
So it's not currently used?
The Nivian isn't, no. But the original Medtronic Valiant Captivia graft is still available. It just highlights that even after approval, monitoring device performance is crucial.
Absolutely. Post-market surveillance is key. Okay, let's move to the Cook Zenith Alpha device.
Approved September 2015. Again, a key goal was lower profile, 16 to 20 French, plus that hydrophilic sheath for smoother delivery.
Seeing a trend here.
Definitely. The Alpha graft is a 2-piece modular design. External nitinol stents, woven polyester fabric. It has external graft lining at the ends for better contact with the aorta, and active fixation barbs like the older Zenith TX2 to help anchor it.
What else is notable?
It has something called a proform proximal suture to help it conform better in the arch, reducing the risk of infolding. Uses trigger wires for deployment. Has gold markers for visibility on X-ray. Comes in straight and tapered versions.
How did it perform?
The one-year data looked pretty good. Low rates of major ental leaks, low reintervention, and again, that lower profile helped percutaneous access in over a third of patients in its trial. Only one needed a surgical conduit.
Good. And finally, the Terumo Aortic Relay Device Plus.
Approved September 2012.
Right.
This is the third generation of what used to be the Bolton Relay. It's a one-piece graft, woven polyester on self-expanding nitinol stents.
Key features.
It has a pre-curved nitinol support, strut for stability, and conforming to the aorta's curve. Hydrophilic braided outer sheath for delivery. Comes in bare stent for active fixation and non-bare stent versions. Straight and tapered designs. Recommended oversizing is 10% to 15%.
Anything unique about its deployment?
The leading edge stays constrained until the surgeon releases it, which helps prevent that windsock effect where it catches the blood flow and opens prematurely, potentially misplacing it.
Sure.
And it offers some of the longest T-VAR graft lengths available, up to 250 millimeters. The Restore registry in Europe showed about 10% 30-day mortality and 9% reintervention at 2 years. Terumo also has a newer, lower-profile version, the Relay Pro, so continuous innovation.
Okay, so a good range of devices with different features. Once the device is chosen, the next huge step is planning the procedure. Sounds like this needs extreme precision.
Extreme is the right word. Careful anatomical assessment, meticulous preoperative planning, absolutely paramount for success. You have to confirm you have good arterial access for the device and nail down exactly where those landing zones will be for a secure seal.
And the main tool for this planning?
The cornerstone is that high-resolution preoperative CT angiography, the CTA, needs to cover from the neck all the way down through the femoral arteries in the legs.
Gives you a whole roadmap.
Exactly. And crucially, we use 3D centerline reconstructions from that CTA data. That lets us accurately see the tortuosity, the twists and turns, pinpoint the landing zones, figure out the best access sites, and size the graft components precisely.
We talked about access challenges earlier. What specific things are you looking at in the aortoiliac femoral vessels?
Well, back in the early days, open surgical cut-downs to expose the artery were common because the sheaths were so big. Now, with lower profile devices and better closure techniques, we're doing much more totally percutaneous access.
But you still need decent vessels.
Absolutely. You need enough diameter. Less than 7 millimeters is tough. Significant calcification, plaque, lots of twists. Those are all challenges, especially together. The right common femoral is often preferred for insertion.
And you need, what, 7 or 8 millimeter minimum diameter?
Ideally, yeah. 7 millimeters for a 22 French sheath, 8 millimeters for a 24 French. The narrow spot is often the proximal external iliac artery, especially in women.
What if it's too narrow?
That's where iliac conduits used to be common. Maybe 15% of cases needed them. Surgically sewing on a graft segment. Or sometimes you can access the common iliac higher up. Or rarely use alternative access like the aorta itself or subclavian.
You mentioned an internal endoconduit technique?
Right. That's for tough iliacs. You deploy a covered stent, like 10 or 12 millimeter, inside the diseased iliac, inflate it aggressively to create a bigger, safer pathway for the T-VAR sheath.
Clever workaround.
It can be. But thankfully, with the lower profile sheaths and better wires now, we need these extra maneuvers less often than before.
So access is one major hurdle. What about the aorta itself? Can its shape cause problems?
It certainly can. The abdominal aorta is usually okay, but the thoracic aorta, especially with an aneurysm, gets tortuous, twisty, and elongated.
The aneurysm stretches it out.
Yeah, head-to-tail elongation increases the curves, especially that curve as it goes through the diaphragm. This tortuosity, plus maybe a sharp angle between the arch and the descending part, makes tracking that stiff delivery system tricky.
Like threading a needle through a winding tube?
Exactly. The system can kink or bend, making precise placement difficult.
Okay, so navigating the path is complex. Once you're there, you need to land the graft securely. Talk about these landing zones.
Critical. Adequate fixation in healthy aorta, both proximal and distal, is essential for durability. The general rule is you need at least 20 millimeters of normal-looking aorta for a good seal.
20 millimeters, is that always enough?
Not always. If you're landing in a curved or angled segment, you really want more, maybe 25 to 30 millimeter to be safe.
And there are specific zones defined.
Yes. The SVS has reporting standards with 11 zones, numbered 0 through 11. Zone 0 starts way up proximal to the innominate artery in the arch. Zone 1 is between the innominate and left carotid. Zone 2 between left carotid and left subclavian. Zone 3 just distal to the subclavian, and so on down to the iliacs.
And where you land matters for risk.
Absolutely. The proximal landing zone location is strongly linked to the risk of neurologic events, like stroke.
So closer to the brain, higher the risk.
Generally, yes. And while 20 millimeter might be okay further down, in those angled segments near the arch, you want that longer seal zone to reduce leaks, type I endoleaks, and prevent migration. But you have to balance that
Against what?
against covering too much aorta, which increases the risk of spinal cord ischemia. It's a trade-off.
Where's the ideal spot to land then?
Ideally, you want relatively parallel aortic walls, distal to the left subclavian artery, and proximal to the celiac artery, if possible.
What makes landing near the arch tricky?
The curves. Trying to seal in a sharp curve, especially near the left subclavian, is tough. The graft is relatively stiff longitudinally. It might not fully conform to the inner curve.
Leading to gaps.
Exactly. You can get what's called bird beaking, where the graft angles away slightly from that inner curve, increases the risk of failure and type I leaks. So in those cases, you focus on getting seal length along that inner curve.
Got it. And you have to watch out for accidentally covering branches.
Meticulously. You need centerline measurements, 3D imaging, to check proximity to major branches. If you have to cover one, like an arch vessel, you might need that aortic arch debranching surgery we mentioned.
Or the less invasive options.
Right. Branched endografts, in situ fenestration, making holes, chimney snorkel techniques, all ways to extend the proximal zone while keeping vessels perfused.
So that precise imaging is non-negotiable for this planning. What exactly is involved?
Fine-cut gated CTA is the absolute workhorse, ideally 128 or 256 slice scanner. Gated means timed with the heart to reduce motion blur.
Giving you super clear pictures.
Exactly. Allows for great 3D rendering, plus those crucial sagittal and coronal reconstructions. And specialized software gives you even more.
Like what?
Orthogonal reconstructions perpendicular to blood flow for accurate diameter measurements. Some even let you do virtual graft simulations in the patient's anatomy. Really helpful for planning size and placement.
What if someone can't have a CTA? Kidney problems, contrast allergy.
Gated MRA, magnetic resonance angiography, is the alternative. SVS supports it, but acknowledges the evidence isn't quite as strong as for CTA for planning T-VAR specifically.
And the scan needs to cover everything.
Neck to groin, essentially. Entire thoracic and abdominal aorta, iliacs, femorals, with and without contrast dye.
Why both?
Lets you see the vessel wall, calcification, thrombus properly. And sometimes, if you might encroach on the arch vessels, you include the head and neck too.
To check brain circulation.
Yeah, assess the vertebral arteries, circle of Willis. SVS strongly recommends that if you're landing near the arch vessels, 3D is key for seeing tortuosity, any mobile plaque in the arch, and exactly where those vertebrals are if you're landing in zone 0, 1, or 2.
And you also check pelvic perfusion. Why?
To assess the risk of spinal cord ischemia, especially important if they've had prior aortic surgery or if you're planning very long aortic coverage, need to understand those collateral pathways.
Okay, that detailed imaging gives you the map. How do you then use it to pick the right size graft?
Sizing is critical. And you have to be careful not to go too big. Overzealous sizing is bad.
Why? What happens if it's too big?
It can cause the graft material to infold, create gutters where blood leaks those type I endoleaks again, or even damage the aortic neck over time from too much outward force.
So how do you measure accurately?
Best way is using those orthogonal reconstructions from the CTA, especially in curvy or angled bits. Short axis diameter is a decent estimate if you don't have orthogonal views readily available.
What makes sizing tricky?
The diameter of the neck where you need to seal can vary between the top and bottom landing zones. Plus, getting the length right is tough because the aorta curves naturally and the aneurysm exaggerates that.
So a straight line measurement isn't accurate.
Not usually. A 3D centerline flow measurement gives the best length estimate, though even that can sometimes slightly underestimate as the graft tends to follow the outer curve.
So best practice is using that 3D software.
Definitely. SVS strongly recommends using 3D centerline reconstruction software for both planning and during the procedure itself. Optimize the sizing and graft choice.
Okay, Matt made access plan graft-sized. Now, a huge concern, especially near the arch, is blood flow to the brain and spinal cord. How do you manage that risk during planning?
Paramount consideration, absolutely. Often you don't have perfect long landing zones available. Some trials show they had to extend proximally into zone 2, near the left subclavian, in over 20% of cases to get a good seal.
And covering that left subclavian artery, LSA, can be problematic.
It can be. While many people tolerate it okay due to collateral blood flow, routine LSA coverage is discouraged. The LSA feeds the left vertebral artery to the brain and also contributes to spinal cord supply via internal mammary and intercostals.
So blocking it isn't always safe.
Not always. Early on, surgeons often did preemptive bypasses if they planned to cover it. Later studies suggested maybe that wasn't always needed. But the current thinking, the evidence now, strongly favors preserving LSA flow whenever possible.
To minimize risk.
Right. Minimize risk of brainstem stroke, spinal cord problems, and left arm issues. It's especially critical if the patient has a dominant left vertebral artery.
How common is that?
Over 60% of people have a dominant left vertebral, often with an underdeveloped right one. Covering the LSA without revascularization in those folks significantly increases stroke risk.
Any other data supporting that?
Yeah, the big Eurostar registry found LSA coverage without bypass was an independent predictor of spinal cord ischemia after T-VAR. So assessing those vertebrals is vital if LSA coverage is on the table.
So understanding that individual collateral network is key.
Totally. Pre-op CTA needs to check the right vertebral artery size and connections, the completeness of the circle of Willis in the brain. This flags patients at higher risk if the LSA is blocked.
Are there times when bypassing the LSA is considered mandatory?
Yes, definite indications. Dominant left vertebral or hypoplastic right vertebral. If the left vertebral feeds directly into the PI-CA in the cerebellum, incomplete circle of Willis, an aberrant right subclavian artery, blocked internal iliac arteries bilaterally, or if the left vertebral originates abnormally from the arch.
Wow, quite a list. Any other reasons?
Clinically, yes. If they have a patent lamitalad heart bypass graft coming off the subclavian, you need to preserve flow, or a functioning left arm dialysis access.
Okay. And maybe for extensive repairs, too.
Right. Revascularization is often advocated for long segment coverage over 150 millimeter, or if they've had prior infrarenal aortic surgery, to lower that paraplegia risk. SVS gives that a grade 1B recommendation.
How is the revascularization actually done? What are the options?
Usually either a bypass graft from the left common carotid artery to the subclavian, or a subclavian transposition, where you surgically move the subclavian over and connect it to the carotid.
Pros and cons.
Transposition avoids ligating the LSA origin, which can prevent a type 2 endoleak from backflow, but it's technically harder, especially if the LSA itself is diseased.
So the bypass is more common?
Often, yes. Carotid subclavian bypass with the prosthetic graft combined with ligating or coiling the LSA origin. But that approach has its own risks, potential nerve injury in the neck, schizophrenic recurrent laryngeal, neck hematoma.
These debranching procedures sound critical for extending that proximal landing zone safely. What about even closer to the heart? Zones 0, 1, 2.
Yeah, when aneurysms involve the arch itself, maintaining flow to all the great vessels is even more critical and complex. Standard T-VAR often isn't enough.
So what are the strategies there?
Several options. Specialized branch T-VAR devices with side arms for the arch vessels, hybrid procedures combining open surgery and endo techniques like in situ fenestration, extra anatomic bypasses, endovascular debranching with chimneys or snorkels, or full open surgical arch debranching.
What's the goal of all these complex approaches?
Extend the proximal landing zone into healthy aorta, keep those crucial branches perfused, lower the risk of type I leaks, and minimize adverse events overall.
What about aneurysms right near the left common carotid?
Challenging. If you need to cover the carotid origin for a seal, the most common fix is an extra anatomic carotid-to-carotid bypass, usually with a 6mm PTFE graft, often done via neck incisions to avoid sternotomy. Need to be careful not to compress the esophagus with the graft, though.
What if the inflow from the right carotid isn't good enough?
For very high-risk patients, you might consider sequential bypasses, like femoral axillary then axillary carotid, or endovascular debranching of the left carotid using a chimney stent parallel to the main T-VAR graft, often reinforced. Data is limited, but it's an option for some.
And if the innominate artery is involved? Zones 0 and 1.
That's the toughest. Usually managed either in clinical trials for branched arch devices or with open arch debranching via sternotomy.
How's the open debranching done?
Typically, so a bifurcated graft onto the ascending aorta, then connect the limbs to the innominate and left carotid. The T-VAR graft is then deployed distal to that reconstruction. Complex surgery.
Okay, we've covered head and arm vessels. What about the big ones supplying the gut celiac and SMA, especially for the distal landing zone?
Another crucial point. Whether it's safe to cover the celiac artery origin depends heavily on the collateral circulation between the celiac and the SMA via the gastroduodenal and pancreaticoduodenal arcades.
So if collaterals are good, covering the celiac might be okay.
Study suggests yes, in some cases, without causing bowel or spinal cord ischemia. But if imaging suggests poor collaterals, preserving celiac flow is a high priority.
How can you preserve it if you need to land there?
Periscope grafts are one option, especially if open bypass isn't great for the patient. You place a covered stent retrograde into the celiac origin from the femoral artery before deploying the main T-VAR graft over it. Might need reinforcement due to forces there. Useful for preserving branch vessels in seal zones.
What if the SMA itself is narrowed?
If the SMA has significant stenosis, 50%, SVS actually recommends stenting the SMA before doing a T-VAR that covers the celiac to ensure gut perfusion.
And if risk of celiac ischemia is high overall,
Then an open bypass or dedicated endovascular intervention to maintain celiac flow is strongly recommended. Another trick is placing prophylactic guide wires into the celiac and/or SMA during the T-VAR.
as a safety net.
Exactly. If you inadvertently cover one, you have immediate access to potentially stent it open.
Wow. It is an incredibly complex planning process, so much to consider. Once the plan is set, walk us through the actual T-VAR procedure, key steps in the OR.
Okay, so the access site, usually the common femoral artery, is chosen beforehand. Access is gained, they're open cut down or percutaneously. Then, a stiff guide wire is advanced under X-ray guidance up into the ascending aorta.
Careful navigation needed.
Very. You mark the wire to detect movement. If the iliacs are twisty or narrow, stiffer wires and hydrophilic sheaths help. Sometimes you need higher access in the common iliac.
And if the vessels are just too small?
That's when you might need that surgical conduit sewing a Dockerin tube onto the iliac artery for a larger entry point, or the internal endoconduit stent technique we mentioned. SVS supports both when needed.
Okay, wires up, then what?
Access the other groin, or maybe an arm artery for a smaller diagnostic catheter. Inject contrast dye to do an aortogram, an X-ray picture of the arch. Pre-op CTA tells you the best angle to view things.
Like a roadmap confirmation.
Exactly. For the distal landing zone near the celiac, a near lateral view is often best. And remember, SVS recommends preemptively stenting a narrowed SMA before covering the celiac. Prophylactic wires in celiac SMA can be helpful too, just in case. Same for LSA protection via brachial access if needed.
Got it. Now bringing in the main device.
Right. Introduce the T-VAR endograft system over the wire under fluoroscopy. Use aortography, maybe IVUS, intravascular ultrasound, or T, transesophageal echo, to guide positioning. IVUS is great if the CT quality wasn't perfect.
How do you advance it carefully?
Advance gently past the target landing zone, then pull back slightly to remove stored energy in the system helps prevent jumping. Steady forward pressure on the wire helps keep it against the outer curve.
What if the aorta is really sharply angled?
Tricks include using buddy wires for support, longer sheaths, deploying a distal graft piece first for stability, or even that body floss technique with a wire snared from below.
And if multiple graft pieces are needed?
Usually deploy the smallest diameter piece first. Overlap same diameter pieces by at least 7.5–10 centimeters. For more than 2 pieces, often land the proximal and distal ones first, then bridge between them. Sometimes, for big proximal aneurysms with distal twists, deploying the distal graft first helps stabilize things.
What about blood pressure during deployment?
Temporarily lowering the mean arterial pressure helps, especially for proximal deployment in the arch. Reduces the windsock effect. Rarely, you might use adenosine to briefly stop the heart or rapid pacing for very precise arch deployment.
Okay, graft is deployed. What next?
Completion imaging. Angiography, maybe cone beam CT or IVUS to confirm placement, check integrity, and rule out endoleaks, especially type I or 3.
What if you find a leak?
Address it immediately. Balloon inflation to improve the seal, maybe deploy extension cuffs, or use endoanchors to staple the graft to the wall.
Then finish up.
Carefully remove the large sheaths, avoiding iliac injury. Angiogram the access vessels after removal. Always keep wire access until the very end, just in case you need to quickly fix an access site injury with a covered stent.
It sounds like an incredibly intense choreographed procedure. What's the immediate recovery like? Post-op management.
Post-op, they go to a monitored setting, usually ICU. Frequent neurovascular checks are key, looking for access site, hematoma, leg ischemia, signs of stroke, or spinal cord ischemia, SCI.
What about if they had a spinal drain placed?
If they had one for neuroprotection and their neuro exam isn't reliable yet, keep the CSF pressure around 10 centimeter H2O. If they wake up okay neurologically, cap it, remove it the next day usually.
And blood pressure management.
Keep the mean arterial pressure modestly elevated, maybe 80–85 millimil HD-Phi. Helps perfuse the spinal cord. Higher if they show any new deficit.
How often are neurochecks done?
Frequently at first, every 30 minutes for 6 hours, then hourly for the next 24 hours or so.
What if they develop a deficit?
Back to ICU immediately if not there. Push the MAP up. Pharmacologically, maybe 100 millimil Hg. Insert a spinal drain emergently if they don't have one. If symptoms resolve, keep MAP 90 at discretion.
And if they don't improve quickly?
Neurology consult. Usually an MRI of the spine within about 4 hours to look for spinal cord infarction. Time is critical.
Okay. And assuming things go well initially, what's the long-term follow-up plan?
Standard protocol involves a checkup at 1 month post-procedure. History, physical exam, and crucially, another CTA scan of the chest and abdomen, with and without contrast, including delayed images.
Why delayed images?
Helps pick up subtle endoleaks that might fill slowly.
And if that 1-month scan looks good?
And then the recommendation is annual CTA surveillance for life. Lifelong.
Every single year.
That's the current SVS guideline, grade 1B recommendation. If the 1-month scan shows issues, like a small leak, you might do more frequent scans initially, 3, 6, 9 months.
Can MRA be used instead of CTA for follow-up?
Yes, MRA can be used, especially if there are contraindications to repeat CTs. Most modern endographs are MRI compatible, but the optimal frequency is still debated, balancing surveillance needs against radiation, cost, inconvenience.
What do you do if follow-up imaging does find a problem?
Type I, or 3 endoleaks, leaks at the seals or through the graft, generally need prompt evaluation for treatment, usually another endovascular procedure.
What about type 2 leaks from branch vessels?
Those can often just be watched with continued imaging if the aneurysm sac size is stable. If the sac starts growing, then intervention to fix the type 2 leak might be needed.
Okay, we've covered a ton of detail on the procedure itself. Now let's talk results. How well does T-VAR actually work in the real world, based on the evidence?
It's a bit complex because large head-to-head randomized trials comparing T-VAR directly to open surgery are scarce. So a lot of our long-term data comes from industry-sponsored device trials and large registries.
And technology keeps changing.
Exactly. Data from older devices might not fully reflect current outcomes. Plus, registry data often lumps together different aneurysm types, patient risks, devices, urgency levels. Makes direct comparisons tricky. Other societies like STS and ESVS also have guidelines, often based on earlier generation tech.
Understood. But looking at the available trials and data, what can we say about technical success and early outcomes?
The main FDA pivotal trials for the Gore, Medtronic, Cook, and Terumo devices give us good insights, mostly from elective procedures in relatively good-risk patients. Technical success, getting the device deployed correctly, excluding the aneurysm, no major leaks at the ends is generally very high, 98% usually.
And clinical success.
That looks at things like aneurysm-related death, rupture, leaks needing fixing, reinterventions. Across the trials, patient demographics were similar, mostly men, over 70, aneurysm 50 millimeter. Most technical failures that did happen were access-related, even with conduit use sometimes.
But newer devices have fewer access issues.
Yes, the lower-profile Valiant EVO, Zenith Alpha, Gore Surpass trials show fewer access problems, more percutaneous access, conduits rarely needed now.
How many graft pieces are usually needed?
Depends on aneurysm length and device options. Average may be 1.6, but some trials like Valor average 2.7, almost always needing more than one. And extending into zone 2 proximally for a seal was common, nearly 20% overall, 33% in Valor.
What about perioperative outcomes like mortality?
Early experience with first, second-gen grafts in high-risk folks had higher mortality but proved feasibility. Third-gen trials show much lower 30-day mortality, like 1 to 2.2%, which is way better than the 7% historically for open repair.
That's a big difference.
It is. Terumo Relay Plus trial was 5.3% T-VAR versus 10% open, though some T-VAR deaths were procedure-related. But recent trials with Gore CTAG, Cook Zenith Alpha show very low mortality, 0 to 2.8%. Operative mortality beyond 30 days also favors T-VAR.
So early survival benefit seems clear.
Yes, especially compared to older open surgery data. Early comparative trials showed T-VAR operative mortality around 2%, 8.5% for open. Meta-analyses confirm T-VAR reduces perioperative mortality and major neurologic issues.
But you mentioned equipoise long-term.
Right. Beyond that first year, the survival curves tend to merge. And emergent T-VAR still carries high-risk care. NSQIP data shows 23% 30-day mortality versus 6.2% for elective. Emergency status, complexity, kidney disease, drive up risk.
Okay, so early benefits are strong. What about longer-term results, say out to 5 years?
We have 3 5-year data from trials like Cook TX2, Gore TAG, Terumo Relay Plus, Medtronic Valiant. 1-year results reinforce that early T-VAR benefit, mainly in aneurysm-related survival.
So the difference was mostly upfront risk reduction.
Largely, yes. But when you look at all-cause survival long-term, The difference between T-VAR and open becomes minimal after year 1.
Similar overall survival of 5 years.
Remarkably similar in the Gore tag, 68% to 67%, and Cook TX2, 62.9% to 62.8% trials. Suggest both are effective long-term at preventing aneurysm death, but overall survival depends more on other health issues.
What about in very high-risk patients?
Outcomes there are less encouraging sometimes. That Stanford series showed only 31% 5-year survival after T-VAR in high-risk patients versus 78% for open candidates. Raises questions about doing any invasive procedure in some asymptomatic high-risk folks.
Right. Now, let's talk complications more specifically. How does T-VAR stack up against open repair in terms of major adverse events?
Generally favors T-VAR. Cardiopulmonary issues are common in both groups, older patients, atherosclerosis, but usually less frequent and severe with T-VAR.
Can you give an example?
Sure. In the Cook TX2 STARS trial, 30-day cardiovascular complications were 15.6% for T-VAR versus 44.3% for open. Pulmonary was the same split. Blood loss, hospital stay, also strongly favor T-VAR.
Okay. What about those vascular access complications we discussed? How common are they now?
Rates have come down. Early Gore tag was 14%, but dropped to 6% in a later trial with experience. Recent reports are more like 5–7%. Serious iliac injuries are less common, but still a risk, hence the push for conduits or endoconduits in tough cases.
And the newer low-profile devices help.
Definitely. Zenith Alpha study, 98% success, no conduits needed, though 2 patients couldn't get the graft due to iliac disease. Valiant Navian study, over 50% percutaneous, no access adverse events, Gore tag active control, low rates too. Even the older Bolton relay trial had few access failures with its original system. Big improvements here.
Good. Now, neurologic complications, stroke and SCI. You mentioned similar stroke rates overall.
Around 3–8% for both open and endo. Risk factors for stroke with T-VAR include mobile plaque in the arch, prior stroke history, and deploying proximal to the left carotid risk of emboli.
Does placement matter?
Early studies suggested higher stroke risk with more proximal. Zone 2 deployment. Gore tag showed 14% is 1%. Recent studies show variable rates, 0.8 9.8%. Technique is key. Minimize manipulation, careful flushing. Eurostar link female gender, and long procedure time to stroke.
What about spinal cord ischemia, SCI, paraplegia risk?
TAAs showed a big advantage early on. Gore tag, 3% EVAR versus 14% open. Pooled early trial data, 6.2% EVAR versus 13% open.
But some open centers report lower rates.
Yes, around 2.53% permanent paraplegia, with open, citing techniques like distal perfusion, hypothermia, maybe patient selection. But a recent open cohort still showed 8.6% CCI, including weakness. Even just looking at permanent paraplegia, T-VAR seems favored. Pooled early rates, 1.6%, backpoint Visius, 5.1%.
Why lower SCI with T-VAR?
Likely avoiding aortic cross-clamping, maybe less hemodynamic upset.
What increases SCI risk after T-VAR?
Prior infrarenal repair, extensive thoracic coverage, kidney problems, low blood pressure during surgery, covering hypogastric arteries, or the LSA without bypass.
We talked about LSA coverage risks.
Right. Eurostar linked it independently to SCI. Practice now leans towards more LSA revascularization. Also important are pelvic collaterals via internal iliacs. Need to preserve flow there if possible, maybe stage repairs.
So prevention is key.
Absolutely. Limit sheath time in iliacs, keep VP elevated. Aggressive neuroprotection protocols are used by some centers. Low SCI rates in recent device trials, 0.2%, suggest these strategies work. Intraoperative protection, not just rescue, is the focus.
Okay. What about endo leaks? How common are they after T-VAR?
Rates varied a lot in early trials, partly due to definitions. Valor was high, 26% early, others lower. TAG 3.6%, STARS 4.8%. At 1 year, maybe 4–12%. Long-term TAG data showed 4–8% out to 5 years. Incidence seems to be decreasing with better devices. Recent studies show 2.5–8.4% early on.
What types are most common?
Varies. TAG had more type 3, seal or graft issues. Others reported more type 2 from branch backflow. Newer devices show low rates of type 3 requiring intervention. For example, Medtronic Navian had only 2.5% total leaks early, no reinterventions. Cook Alpha had some type ILF needing fixing. Gore C-TAG Surpass also had a few type ILF needing intervention.
So type I and 3 are the ones usually needing fixing?
Yes, they account for most secondary interventions. And achieving that recommended 0.2 centimeter landing zone seal is critical to prevent them.
What about the aneurysm sac itself? Does it shrink? Does it ever get bigger after T-VAR?
Sac shrinkage is the goal, shows the repair worked. Early studies showed sac enlargement, 5 millimeter and 7–14% at 1 year. The Gore tag trial showed 20% enlargement at 5 years, but maybe linked to graft porosity.
Others showed better results.
Yeah, Talent and Cook TX2 trials had 84-90% with shrinkage or no change at 5 years. Modified tag graphs showed less enlargement, 14% at 3 years. Cook Alpha only 3.4% growth at 1 year. Terumo Relay was 15% at 5 years, though, so long-term surveillance is still needed. SAC growth means ongoing pressure.
And the graphs themselves, do they stay put? Do they break? Migration or integrity issues?
Late migration 10 mm shift is uncommon, 5% overall, less frequent with newer devices, 0.73, 0.9%. Risk factors include poor initial sizing, tortuous seal zones.
How low are rates now?
Gortag reported no investigator-reported late migrations at 5 years, though Core Lab found some minor shifts. Cook TX2 had 12 over 5 years, mostly due to bad neck anatomy. Talent reported very few. Cook Alpha and Gore surpassed none or 1 case at 1 year. Relay also low incidence. Structural failures like stent fractures are rare, but possible long-term.
Okay, so with these potential late issues like leaks or migration, how often do T-VAR patients need more procedures later on, secondary interventions?
Early reinterventions, first year, were around 2-11% in pivotal trials, mostly endovascular fixes. STARS-E TX2 showed similar 1-year rates for T-VAR and open, around 4-6%. Cook Alpha and CTAG Surpass had low 1-year reintervention rates, a few percent, mainly for leaks.
What about longer term?
Gortag actually showed slightly higher reintervention for T-VAR at 5 years, 15% says 32% open. But the open reinterventions were mostly for wound other issues, while TAAR ones were for endoleaks graft issues. Few conversions to open surgery were needed. TAG had 2 early, Valor 4, Restore 2, usually for infection, migration, fistula.
So repeat endo procedures are more common after T-VAR than repeat open after open.
Generally, yes, for fixing graft-related problems. Terumo Relay has 7.5% needing secondary procedures over 5 years, mostly for leaks. But late open conversion after T-VAR is rare, though possible for complex issues like infection or major device failure. Mortality for those conversions can be significant, around 9%.
This has been an incredibly thorough deep dive. Thank you for walking us through all of that complexity.
You're very welcome. It's a fascinating and evolving field.
So just to quickly summarize the key takeaways for you, our listener, T-VAR really revolutionized treatment for thoracic aortic aneurysms after its approval in 2005. It's often preferred now, especially initially, because it's less invasive and generally has better early outcomes than open surgery.
Definitely lower upfront risk.
But careful patient selection is absolutely critical aneurysm factors, patient health, and that meticulous preoperative planning with detailed imaging and landing zone strategy are non-negotiable.
Can't stress that enough.
The technology keeps improving, aiming for better long-term durability and fewer complications like leaks or spinal cord issues.
Continuous refinement.
And while T-VAR wins early on, long-term outcomes seem more comparable to open surgery, highlighting the absolute necessity of lifelong surveillance after T-VAR.
That follow-up is key.
Finally, T-VAR is adaptable. Techniques like debranching and branch management let us treat more complex cases endovascularly.
Expanding the possibilities. That's a great summary.
So thinking ahead, as this T-VAR technology and physician experience just keep evolving, what do you think the long-term future holds? It really feels like a field in motion.
That's the perfect final thought to leave you with. Given these ongoing developments, what will the treatment landscape for thoracic aortic aneurysms look like down the road? How might things like patient age or their specific risk factors further shape that choice between endovascular and open repair? It's a dynamic and really critical area. I'd encourage anyone interested to dig into the references and keep following the research. It's definitely not standing still.